For those of you who don't know me, my name is Jennifer Gillick, and I am the program director here at APDA Northwest. And we are very lucky to have a fantastic panel of folks here to talk about innovations in deep brain stimulation. We have a fantastic panel from Oregon Health Sciences University, and we're going to have a very robust discussion. That chat function is where you're going to be able to ask your questions. So this will, if you've been to previous Take Controls, this one's going to be a little bit different because it is a panel discussion. There won't be slides that are up, but it'll be a panel discussion with an opportunity to ask questions afterwards, and then also an opportunity to visit breakout rooms with Medtronic, Abbott, and Boston Scientific, who are the creators of all the DBS equipment, and see the equipment and engage those folks in conversation. So this should be a great day today. Our program is being recorded, and we will put it up on the APDA Northwest YouTube channel afterwards. And you can choose to keep your video on or off, but please do keep yourself muted. The chat function definitely is a place where you can ask your questions. We will be monitoring that. And the icon is right up there on the screen here. So that's what you're looking for on your Zoom screen. This program is made possible by our program sponsors. So Synovian Pharmaceutical and Kyowa Kirin are wonderful sponsors. They are makers of some brand new off medications. And then the 3 DBS device manufacturers, Abbott, Boston Scientific, and Medtronic, are sponsoring this program. So we thank these corporate sponsors for valuing the education programs that we do at APDA and supporting programs like this, because that helps make everything possible. Our mission at APDA is really about support, education, and research that will help people who are living with Parkinson's live life to the fullest. APDA Northwest has been around since 1984, and we serve the 5 states listed here, and really in the virtual world, the rest of the country. And we really locally like to talk about help for today and hope for tomorrow. And that's through keeping people moving through exercise classes, keeping people connected through things like support groups, keeping people educated with programs like these, and providing financial support through our Patient Aid Scholarship Program. And then we also fund critical research. So we do a lot of work in the local area to just help support people living with Parkinson's. Individual donations are very critical to the work that we do. So thank you to those of you who donated when you registered for this event, as well as our corporate sponsors. You make the trains run here at APDA and are really critical in what we do. We can be found. This is all of our contact information, our email, our phone number, our website. We post on social media, so you can follow us and get in touch with us anytime. So enough about me and APDA and everything. You are here to listen to a program about innovations in deep brain stimulation. So I am going to welcome the team from OHSU to the screen, and they are going to show up here on the screen. Shannon Anderson is going to be the moderator for today's discussion. And I am going to tell you guys, we are hoping that you can see this as a panel view. This is the first time that we've done this as a meeting versus a webinar. So we're figuring out all the technology here. So if we turn your camera off or mute you, just bear with us because we want the best view for everybody. So let me introduce Shannon. Shannon is here. She is a physician assistant at the Parkinson Center of Oregon at OHSU. She has been the clinical coordinator for the OHSU Deep Brain Stimulation Clinic for over 10 years. And she is going to introduce the rest of our panelists and moderate this discussion. So Shannon, thank you for being here. Thank you to all our panelists. I am going to hide myself and mute myself and let you guys have a chat, and then I'll come back on at the end to talk about how the breakout rooms are going to work. So thanks very much.
Great, thank you so much, Jen. Before you go away, or maybe Dr. Safarpour, can you hear me okay? Give me a thumbs up.
I can hear you, yes.
Wonderful. Well, thank you everyone for joining us for this panel. We really wanted to do a panel conversation because this really should be a conversation. By no means is this a lecture, as Jen mentioned. We have no slides, no PowerPoint presentations for you. It's just a more fluid discussion. So I have some questions for our panelists today that we'll go through, but I'm really hoping that you will drop your questions in the chat box too, and I'll kind of help field those. One thing that Jen did not mention is that I have the absolute best job in the world, mostly because I get the opportunity of working with great organizations like APDA, but also because I get the chance to work with some pretty remarkable people like the ones on today's panel. So I can't wait for you all to get to know them a little bit better over the next hour. All three are sensational speakers and have a wealth of information and advice for you. So first, I'd like to introduce Diane Hutchins. So Diane has an undergraduate degree in music and a master's in library studies. She was diagnosed with Parkinson's disease after 8 years of searching for answers and not really finding a name to put to the symptoms that she was experiencing until ultimately she got the diagnosis of Parkinson's disease. She underwent deep brain stimulation in 2014. She continues to work as an early learning consultant at the Washington State Library and enjoys reaching out to others with PD through support group facilitation. Diane uses her literary expertise to help others navigate through PD resources, and she uses music as medicine wherever possible. Also, Diane's birthday is coming up, so please join me in wishing her a very happy birthday. We're so happy that she's spending that time with us. Dr. Delaram Safarpour, also here, is a movement disorders neurologist at the Oregon Health and Science University here in Portland. She began her training at Azad University in Tehran, where she received her medical degree. She completed her postdoctoral fellowship in movement disorders at Yale and then went to Philadelphia to complete her residency and internship at Temple University, followed by a movement disorders fellowship and a master's degree in clinical epidemiology at the University of Pennsylvania. And then we were finally able to convince her to come to the Pacific Northwest, to the West Coast, and join our team. And she's been such an integral member of that team, including as the medical director of our Deep Brain Stimulation program since 2017. Our third panelist is Dr. Kim Burchell, who I believe will be joining us shortly. He's on his first vacation in a number of years right now, so he was having some issues with the call-in, so I will ping him in when he arrives. But Dr. Burchell is a functional and stereotactic neurosurgeon and the surgical director of our DBS program at OHSU. He and Dr. Safarpour really help us to move that program forward. He was the chairman at the OHSU Department of Neurological Surgery for over 25 years. He's published more than 300 peer-reviewed articles and chapters, and he's internationally recognized as an expert in deep brain stimulation. He was the first neurosurgeon to perform deep brain stimulation in the United States close to 30 years ago. So that's our esteemed panel. I think what I'd like to do is kick off the conversation with you, Dr. Safarpour. So I think we all know, from videos and hearing from other folks who've had DBS that it can be a pretty remarkable procedure, but it's certainly not for everyone. And so one of the more key innovations in DBS and in the DBS world is to ensure that the right person has the procedure. So how do you approach identifying who that right person is who would benefit from DBS? And what do you find to be the most useful advance in candidacy selection that you've seen during your career?
Thank you, Shannon. And that is a great question. And I want to make that two questions. First, who's a good candidate for surgery? Often we are asked about this by the patients. They say someone they know had the surgery and had a very bad outcome, and someone else had the surgery and their outcome was really good. The most important thing that I always advise all the patients is that if you want to learn more about DBS and your candidacy, it's most important for you to do that through a center that has multidisciplinary team. Multidisciplinary team is important because your candidacy is really evaluated by a number of different people, a number of different specialists who have had extra training for DBS to comment about your candidacy and say whether or not you will have good outcomes from the surgery. That team will include, importantly, the surgeon, a surgeon who's had good experience, has done a number of these procedures over years and is able to do the surgery without any problems, and a neurologist who's able to program after surgery and who's able to evaluate before surgery to say whether or not you, first of all, have the diagnosis that is correct. Because when we're talking about Parkinsonism, we have people who have Parkinson's disease, idiopathic Parkinson's disease, we call it, and people who have atypical Parkinsonism. It's important to not do the surgery on people who have atypical Parkinsonism because we know that the outcome is not going to be good for those patients. So one of the most important steps before the surgery is to identify that the diagnosis is correct, and that will be done by a neurologist who has extra training for DBS. After that, the rest of the team will be physical therapists who will be able to examine the patient in an on and off state. When patients with Parkinson's disease first start having symptoms, when they take their medications, they may feel that they're on, and that on time is when their symptoms are well controlled, their stiffness, the slowness is well controlled. And the physical therapist will have a detailed evaluation of what improves during that quote unquote on time. Is it their freezing that improves? Is it their stiffness? Is it their slowness? Is it their tremor that improves? And what is their dyskinesia during the on time? And dyskinesia is that extra involuntary movement that patients with Parkinson's disease may have in response to levodopa. So generally we say the best on time that you have, the best response that you have from levodopa or from the dopaminergic medications that you take is the best response that you can have from DBS. You will not improve beyond that with this surgery. If you're on time, that as evaluated by a physical therapist will give you a certain score, that is probably what we hope you will have from the surgery as well. There's an exception here, and that's tremor. If the tremor doesn't quite improve with dopaminergic medications, there's still a chance that tremor can improve with surgery. Actually, that's one of the things that we know surgery will improve. It's also important that the physical therapist does an off-time evaluation because we want to know what is the difference and what's the degree of improvement in symptoms when patients are on. The next member is a speech therapist who will evaluate baseline of speech for patients and will be able to comment on how we should proceed with surgery. Some people who have baseline really poor speech may not be very good candidate for surgery, especially if their speech is really important for them in their quality of life. For example, if this is a reporter and wants to have improvement in their Parkinsonian symptoms, we should let them know that it's possible that speech will worsen, especially if they start at a lower reserve. Another important person in that multidisciplinary team is a social worker. And the reason why social worker is very important is that with DBS surgery, a whole lot of things change. Relationships change. caregiver responsibilities change. And there's a number of evaluations associated with this programming. So we need to make sure who is going to be responsible to bring you for the surgery, who will be responsible for taking care of you after surgery. That's why social workers' role is very important. And then it's also important to have one person who, for example, in our center is Shannon, who's our PA, who's had extreme experience with programming over years and answering questions for the patients throughout their evaluations. And after that, it's also important for a person who brings all of that information together at the end of the evaluation and disclose it to the patients and say, this is what we saw in your evaluations. This is what we recommend. So these are all the different elements of the evaluations. And that's why I say it's very important to have the evaluation in a center that has all these components. And to answer your second question briefly, Shannon, what is the exciting thing, the improvement in the candidacy review is that we've learned over years that it's very important to have evaluations by different specialized people, physical therapists, speech therapists, neuropsychologists that I forgot to mention, who will evaluate to make sure that the patient doesn't have baseline dementia before going to surgery. This is a surgery that can have great outcomes that if it's done on the right candidate. So candidacy selection is the most important step. And over years, I can't tell you how many patients have been referred to our center and we told them that they're not very good candidate for the surgery. And those are probably people who have dementia to begin with, people who have severe depression to begin with, people who have severe balance problems to begin with. And when we hear about their goals for surgery, for example, we tell them that these are things that can get worse after surgery and they probably are not great candidates for it.
That's excellent. Thank you so much for that response. Diane, I have a question for you. So Dr. Safarpour really discussed how the medical team comes up with the right candidate. And sometimes when I have that discussion with patients, I say, we think that the benefits outweigh the risks, but ultimately it's the patient's decision to have surgery or not and decide whether or not that the procedure meets that person's goals, since this is an elective procedure, the patient chooses to do it or not. And so my question for you has to do with if perhaps you could tell us about that moment when you decided, yes, I would like to have elective brain surgery.
Well, for me, I guess it was a no-brainer, and I didn't spend a lot of time thinking about it. I was working full-time as a librarian, and my job was speaking, doing a lot of public speaking, doing a lot of traveling, and I was bothered the most out of all my symptoms. The worst was dystonia in my left leg and my foot, and it's nothing like going out on the road and you're with your colleagues and other people going to dinner, walking to dinner, and your dystonia starts to kick in. And you're trying to pretend like there's nothing wrong. And let me tie my shoe. Let me look at this display window and try to calm the spasm down as best I could. And take my medication. Didn't seem to be really making much of a difference anymore. And I wasn't old enough to reach state retirement at that point. I wasn't old enough for Medicare or Medicaid or Medicare or Social Security. And I was supporting my family and I wanted to keep going until I hit 65. That was the ultimate goal. Just get me to 65. And then if I have to retire, I will. And I was at a conference doing a presentation. It was after hours. I went across the street to a little store to buy some things. And I was going to cross the street back to the hotel. And I was in Wenatchee. I remember that. And my leg started doing its thing. And it's like, oh crap. So I had to go find a bench and sit down and wait for that to pass. And I thought, I'm not going to be able to keep my job if this keeps going on. And so I decided then I have to do this. And I would make the same decision in a heartbeat. It was essential to me continuing to work making it to 65, and it is great.
Great, thank you for sharing that. Um, Dr. Safarpour, there are a couple of different ways to do the surgery, and we seem to sort of group them into what we call awake DBS versus asleep DBS. And the awake asleep is whether or not the patient is under anesthesia or asleep during the procedure, or if they're awake and participating in that procedure. Can you tell us a little bit about the difference beyond just whether or not there's anesthesia, and what the pros and cons are between those two?
Yes, absolutely. So, so these two procedures, as you said, are different in a way that during an awake procedure, the patient is awake and is able to kind of hear what's going on in the OR, and they will examine the patient. The way that they approach the target, the way that the surgery is done is slightly different. But from a patient experience, what's different is in an awake surgery, patients should be able to present to the day of surgery in an office state, meaning they don't take their medications that day. Make them a little uncomfortable. Some people will say that I'm so stiff that I have back pain, or when I don't take my medications, I'm very anxious and my anxiety, my depression is worse, and my tremor is so bad that it makes me uncomfortable to be on the table for surgery. Then probably that person will not have a good experience from the surgery. You know, it's going to be hard for them to sit through it and be able to cooperate. Whereas some other people are completely fine with being off of their morning dose of medication for 4 hours and can tolerate hearing what's going on and this in the operation room, and this doesn't make them anxious. There are centers that offer both of these procedures, awake and asleep, but there are some other centers that have found that a sleep procedure, like our center, a sleep procedure is what is often asked by the patients, and the results we're finding are probably as good, and in some areas maybe even better, because the patient comes in, goes in under anesthesia, wakes up, the surgery is complete. They don't need to be off of their medications. They don't need to hear and get anxious about what was going on in the operation room. The length of surgery for a sleep procedure is usually shorter. And so we assume that because they are under anesthesia for less amount of time, their complications will be less. So these are from a patient perspective, what are the differences that patients may experience?
Diane, what was the procedure like for you? What was the operative experience like? Was there anxiety involved? Was there a lot of pain involved? What was the surgery like?
I didn't feel a lot of anxiety. I appreciated, I respected the amount of preparation that was involved to make sure everything was very sterile, and it was kind of a pain, but yeah, you have to do it, but it was okay. I wasn't sure what my hairstyle would be like when I emerged, but it was a nice bald head, and some of the nurses thought I carried it off very well. I taught myself how to make turbans out of silk scarves, so I had a Jane Austen effect going for a while with nice dangly earrings, and it was kind of cool. And people thought I had chemo, and it's like, so people were keeping opening doors for me, and it was nice. Uh, but the surgery, I guess the only thing that was sore was my scalp. I felt my scalp being very stretched. And then there's an area behind my ears where the wires were tucked in between surgeries 1 and 2. And I wear glasses, so that was a little uncomfortable, but I mean, not intolerable. Um, but other than that, it was a very positive experience. I don't think I would have coped well with awake because I get bored after a while. And if you're telling me to do things, my mind's wandering and my response time probably isn't as good as it could be. Uh, so the sleep was very good, and I don't know how long I was out, but I know when I first woke up, I was asking the nurse if I could have a walk around the floor. I mean, like the whole upper, I guess ICU. And then I ate something, and my throat was a little sore from the anesthetic, but other than that, no headache. Nothing. I mean, nothing like that. It was good. And after my second surgery, second part where they connect me up, I was back at work a month. I mean, literally a month to the day after that, and it was a long day. It was like from 7 to 7, and here I am. I'm back, and I was back part time before that. So yeah, I mean, but it was good. I would do it the same way. I really would.
Great. We have Dr. Burchell who has just joined us. So Dr. Burchell, if it's okay with you, I'd like to ask you a question having to do with, I think, the most important innovation when it comes to deep brain stimulation, which is the discovery that high frequency stimulation to certain parts of the brain helps with certain symptoms of Parkinson's disease. And so quite a few years ago, not to age you too much, sir, but a few years ago, you hopped on a plane to France with this idea that you need to see with this idea. And I'm curious about what your expectations and how those changed after you saw the procedure.
Hi, Shannon. I hope you can see me. I'm on the road.
I can, yes.
I'm traveling Long Island, way out on the island here. But so I think your question was about the beginning of all this. And I had, it's a pretty remarkable story. And if you can give me a couple of minutes, I'll talk about it. But I deep brain stimulation in the 80s when I was at the University of Washington, mainly for pain. And it turned out to be not a very successful therapy, but I was aware of the technology and I was interested in the technology. And then actually a neurologist that you might know called John Hammerstedt informed me of in France that was at stimulating the brain to try to reduce tremor. And so I reached out to this individual who I never had met before, actually never heard of him until Dr. Hammerstedt described it to me. And I literally said, this is in the days before email was a really big thing. I sent him I think a fax or something, and he was on the coast of France in Marseille giving some lectures, and he sent me back, just based on an inquiry from someone he'd never heard of either, a very detailed description, including diagrams and all of this data on what he was doing. And in fact, I still have this fax from Aline Benabid, who was my benefactor and professor. And this is on the old fax paper that if you touch it too hard, all of the surface will fall off. And I think it's a historic document, so it's one of the few things I still keep. Gracious to me and completely 100% forthcoming about what he was doing. I think I was really one of the first people that reached out to him and asked him what was going on there. So we made an arrangement for me, myself, and my wife actually to come to Grenoble to watch him work. And again, once I arrived there and met him really for the first time, he was exceedingly gracious to me and my wife, and they took great care of us for a while there. And I watched him do his procedures, and was quite remarkable in terms of what he was doing. He would, Dr. Benabid, I don't think it's a secret, has a little problem of narcolepsy in that he doesn't sleep very much. And literally he was working all day, and from 7 or 8 in the morning in the operating room until often into the evening, and then he would go to his office, get a little something to eat, and then work all night, because he also ran the basic science laboratory there called INSERM. And So he literally slept just an hour or two a night. I never did see him doze off, but I'm sure he did. The pardon me. At any rate, so he was extremely forthcoming to me. In fact, during that visit, he showed me one of the first people he ever implanted in the subthalamic nucleus for Parkinson's disease, and this was in the days when there were 2 generators, and he turned one generator on, and this gentleman who was completely frozen, sitting in a chair, gradually started to move the contralateral side, and then he turned on the other generator and began to move the other side, and within about 15 minutes, this gentleman who was completely frozen in a chair was now literally running up and down the hallway, and was quite remarkable. I thought possibly I was witnessing a stunt, but it turned out to be true. It showed what a remarkable therapy he was on the verge of developing, which was the use of subthalamic stimulation for Parkinson's disease. So when I came back to the US, we actually worked with the FDA. We were able to get a study going here on a investigational device exemption. And that started in 1991, and that was when we placed our first thalamic electrode in a patient from Dr. Hammerstedt to control tremor on one side of the body. This gentleman had already had a thalamotomy on the other side, and so quite remarkable change with stimulation. That was the first one in the US, and that was in November of 1991. So sorry for the long story, and there's a lot of other funny details about that story some other time, but did you get all that?
I did. I love that story. Sharing that with us. It's a remarkable.
And I have to say that I owe a great deal of debt for many reasons to Dr. Hammerstedt for even pointing this out, because it totally changed my life for his suggestion.
It's an amazing story, and it's an amazing dramatic procedure as well. Dr. Safarpour, what Dr. Burchell is explaining about turning the stimulator on and seeing this dramatic effect, as much as we need our surgeon to put it in the right spot, we also need our neurologist to program the stimulator appropriately, or sort of quote unquote find the sweet spot. So I wanted to hear from you some thoughts you have on innovations in finding this sweet spot. I think that's a hot topic right now. Let's start there. Let's just talk about innovations in programming and kind of where you see the field going.
Yeah, that's a great point. And thank you, Dr. Burchell. I love that story too. Such a great story of how you brought the change to US and how it's helping so many people's lives now. So about the programming, once the electrodes are placed, the patients will come back to office to see neurologists in a month. We usually wait a month because this is a time that brains is still going through some adaptive changes to accept the leads, and after surgery, some people will have some improvement in their symptoms, what we call the honeymoon phase, that they feel that their symptoms are better. We always tell them that these symptoms will go away after a month, so don't be disappointed and don't feel that your benefits of surgery has diminished. That's the time that we bring the patients back for programming. And during this time, we try to find out, so each electrode is placed on one side of the brain usually, and each electrode has 4 contacts. This is the old way of how the electrodes were. The more advanced electrodes, the middle 2 electrodes, are what we call segmented, which means that they're not going to stimulate in a ring or a big area of the brain like the earlier electrodes that we had. These are directional, which means that once we create a field of a stimulation in the brain, if the patient has any side effects, and the side effects can be sensory side effects like tingling, numbness, or some people may feel that they have some pulling of the face or the arm. If they have the newer forms, we are able to more easily navigate through these side effects and make a field of stimulation in a way to improve their symptoms without causing the side effects. Now, I saw in the chat that one of our listeners was telling us, Kevin and Barb, they were saying that one of them had DBS 21 years ago. Probably they had the old leads, which are not what we call segmented or directional. That's the older technology. The first thing that I want to tell you is that if you got this surgery 21 years ago, that means that you had improvement in your quality of life for 21 years already. So if you were bothered by your dyskinesia, tremor, stiffness, or slowness, that improved for 21 years. Now, one question is, did you miss anything now that newer technology is out? Are you missing on anything? One of the newest technologies that we have, as I just mentioned, is directional, which helps the programmer create a field that is easier to create without just going through so many different programming techniques to create that improvement. Before, we had so many different techniques in programming to fine tuning in programming when we didn't have directional. Nowadays, as a programmer, it's much easier for us, Shannon and myself, when we program patients, because when we see a side effect, we try to skip that side effect by use of directional leads. And another newer technology perhaps is the rechargeable batteries. Before, we had batteries that had to be changed every 3-4 years. But now we have batteries that can be charged, and now they last longer. We still implant non-rechargeable batteries as well, depending on what the patients really are asking us. Some people don't like recharging their battery very often, every night or every other night. And in those cases, we still place what we call primary sterile, which is non-rechargeable battery. Beyond this, which is something that is still under clinical trials and is still, we're hoping that we will soon have, is what we call closed loop DBS, which is something you can think about it as a pacemaker, where right now what we have is open loop, which means that no matter what state you are in, whether you have dyskinesia or tremor or no, in response to your medications, you're fine. The amount of stimulation that you're receiving throughout the day is the same, is that program that the programmer set you on. So if I've set a program after you come to office, I set you on a program that improves your tremor and the stiffness and dyskinesia, you will be on that program when you go home, no matter if you feel fine or you feel that your symptoms are worse. This is open loop. Brain sensing or closed loop is where this change in a state of the day, for example, some time of the day you are in a better state, some time of the day you have worsening tremor, this will be kind of sensed by the DBS device, and based on that you will have different amount of stimulation delivered to the brain. That's one big advancement that we're still waiting to use that if it becomes FDA approved. It's not still available to us for use, and we will be able to just change the battery that you have, and you will be able to use that technology even if you have the old leads.
Great, thank you. And I want to mention too that we have each of the device manufacturers for the breakout rooms. So I think that I would really encourage you to go to those breakouts, take a look at their leads, take a look at their batteries, have conversations, whether or not you've had deep brain stimulation, to get kind of those more personalized questions answered. Those reps who are here are a wealth of information. Diane, I have a question for you, sort of based off of what Dr. Safarpour said as she was addressing, Barb and Kevin made a comment about quality of life and improvement in quality of life from deep brain stimulation. Ultimately, at the end of the day, that's the goal, right? And so I'm curious to know how having deep brain stimulation has impacted your life, good, bad, or ugly or otherwise.
I'd say definitely good. I don't think I'd be able to function if I hadn't had the surgery. The dystonia was getting worse and worse. The tremors were getting worse. The dyskinesia was getting worse. And I think I'd be in a wheelchair. I really am convinced I'd be in a wheelchair by now if I hadn't had the surgery. And I wouldn't have been able to do all the things was able to do. I was involved in an early learning project that I had some input, not the great lead or anything, but my input was there, and it wouldn't have been, I don't think, without the surgery. Um, and then the activities I'm in now, the volunteer work that I'm doing, I don't think I would have been doing that because I wouldn't have been able to function very well. So it's, I know it's not a cure, but it certainly has improved my quality of life, and I'm very grateful for that, and grateful that Dr. Burchell found that wonderful technique and made my life so much better. And another bonus, my IQ went up 3 points, and it's one of my fears that I'd lose some cognitive ground after the surgery. But and I'm a librarian; it's my bread and butter, is my brain. But that worked out, and it's like, oh, great. So it's a good thing. I got the rechargeable about over a year ago, and I just say if you are considering rechargeable, it's not that bad. Just think of yourself as a cell phone, and for me, it's like, okay, it's 4 o'clock. I'm going to put on a British Mystery and plug myself in and charge, and it's fairly painless. The only thing I would recommend, if you're a full-figured gal, as Jane Russell used to express it, take your bra off to get the sweet spot when you're recharging, because that's a little tricky. That's maybe the tricky part. But anyway, other than that, it's been good. It's been a very positive experience.
Great. I'm going to try and ask another question of Dr. Burchell, if you can hear me. Dr. Burchell, what do you see as innovations in surgical planning or technique or the actual procedure moving forward?
Yeah, thanks, Shannon. Can you hear me?
Yes, I can.
Are you hearing me? Okay.
Yes, I can.
I'm assuming. There have been a lot of improvements since the early days. In the first this procedure, we following the model of Dr. Ben. To be on the operating table awake for 4 or 5 hours. We learned that during the team. What I learned use.
So I'm going to take over because I had a hard time understanding, unfortunately, Dr. Burchell's answer, but I did want to instead
Still here, Shannon.
Oh, are you? Should we try again, Dr. Burchell? Okay, we're going to move on. There is a question from one of the participants. I think Dr. Safarpour, I'm going to direct this to you. This particular participant mentioned neuroma and as well as Parkinson's disease, and both are slow in their progression. One may not even progress, and so the question has to do with if things get worse, should I consider DBS, or would other types of procedures for the acoustic neuroma prohibit DBS? I think global, so certainly specifically about this particular disorder, but I think globally the question is, other things in the body. We don't just have Parkinson's disease, and how those play into the decision to have DBS. Does it weigh into our surgical candidacy, but also does it prevent future therapies and future procedures down the line as well?
Great. That's a very specific question about the acoustic neuroma, because I don't know the size of your acoustic neuroma, and I will not comment on that. I will let your neurologist and neurosurgeon decide on that. If you're generally, you mentioned that your PD has also been moving so slowly. The big question will be, what are you most bothered with? Usually when you're right, Shannon, when patients come in for considering DBS, they may have other problems going on. The most important question that we ask them first is, what is the one symptom that's bothering you the most? You should probably try and solve that first. And if that surgery is such a major surgery that may change your candidacy for DBS, if that symptom, for example, is really driving your worsening of day-to-day life and inability to do your activities of daily living, I usually suggest go deal with that first, and then we will get back to your Parkinson's disease and find out if this is the right procedure for you or not. You are in a good place now. Barbara Sarhan, I think you're in a good place if both of your diseases are moving very, very slowly. In general, in Parkinson's disease, we used to say that the topic of DBS should be discussed with the patients 10 years after onset of symptoms. Then after that, there were studies that compared these patients with those who had DBS earlier, 5 years after onset of their symptoms. We found out that those who have surgery earlier actually have better quality of life. So we start discussion of DBS earlier these days. And usually we say a cutoff of 4 or 5 years after onset of symptoms, once we are sure that the diagnosis is idiopathic Parkinson's disease, is the right time to think about deep brain stimulation surgery, because that can possibly improve your quality of life. So just to give you a short answer to that, the most important procedure that needs to be done first is the one that is affecting your quality of life more significantly.
Great, thank you for that. We are going to try to come back to Dr. Burchell one more time to talk about advances in the surgical procedure and the surgical technique. Dr. Burchell, do you mind addressing where you think the surgery itself is headed in the future?
You hear me, Shannon?
I can now.
Okay, my phone, I've got the video off, that might help. We're going through some not great cell coverage. I'll assume, unless you give me the thumbs down, that you can hear me. But what I said earlier was that in the time that we did DBS, in the first 20 years, we did things much like I learned in France with an awake using what's called microelectrode recording. And that was really kind of the state of the art around the 80s. But as things evolved over the next 10 to 15 years, better imaging technology, better MRI scans, and better computer guidance what we call image guided surgery emerged in our specialty for all kinds of things. And I basically thought this would be a better way to do it than using an awake patient and also using these microelectrodes. So in around 2009, I began to plan for this. We adopted a new technology, changed a number of things. And in 2011, we rolled out the first case where we did a patient completely asleep. We did it based on what's called image guidance using an MRI scan. And then the computer that we the all implemented, and we're now 10 years after that. Now 2021, we've been the procedures have been quite successful. In fact, a few years ago, Dr. Brodsky and a number of us, I believe you were an author on that, and we published a paper that looked at the results of the sleep surgery and compared it to my results from the era prior to doing the sleep surgery, and the results were better. I mean, substantially better for both the stimulation in the subthalamic nucleus and also in the globus pallidus. So and I think that's been our consistent experience since then, is the patients have actually done better, and they have, it's a much less traumatic procedure for the patient because they enter the operating room, within a few minutes they're asleep, and the next thing that happens 3 hours later for us and instantly for the patient wakes in recovery room. So we have stuck with that procedure because it's worked well. The patients seem to like it. In fact, most people now, when presented with the option of an awake surgery, are not very interested. So that's where innovation has really played a big role. A lot of it has occurred in imaging and in the computer guided systems and just our general understanding of deep brain stimulation.
That's great. Thank you for that. We have another question from Frank that Diane, I'm going to have you start out with answering, and then I'm going to kind of back clean up because I think that Frank is wondering about this from kind of a medical perspective as well. But the question has to do with someone who has to travel some distance, a patient with Parkinson's who must travel some distance to have deep brain stimulation studies and the surgery and the programming appointments. How much time should a person plan on being away from home? And I'm sending it to you because that was your experience.
The first part was being assessed whether or not I'd be a good candidate. That was a 2-day, very intense process. I had my procedure done, of course, at OHSU. And so I just scouted around to see were there any inexpensive or relatively inexpensive hotels or B&Bs or what have you, somewhere near Portland to go for that work. Sometimes you can see if the hospital has some sort of an agreement with local hotels or similar facilities. And so I just spent those 2 days, and then I came back when I was approved and set up for surgery, and it was just an overnight stay in the hospital, so it wasn't that bad. The thing that stunned me was how little I had to spend out of pocket. I had a really good plan through my employer, and I kept saying, "You sure? I think it was $2,500. That's it, everything." And they kept saying, "Yes, really." So I was expecting a gigantic bill after hearing that, but no, it was 2,500, I think, total for everything. Yeah, I think the trick though is to check with the facility, the hospital, if they have an agreement with a local place where you can stay, and you can find better rates than AAA or senior housing or whatever, but it's worthwhile. And then I came down for programming, but that was a day trip, so that wasn't so bad. And if you have relatives or friends, it's also an opportunity to get reacquainted.
I totally agree with that. So we are becoming a world in which where we get our care is not necessarily in our backyard. And so one of the nice things, if we can say that, about COVID has really expanded the application of telemedicine. So there are certainly components of the evaluation that we still feel we need to lay our hands on someone and get that nice physical exam and really help assess the candidacy. But there are other components that can be done via telemedicine. Diane did a nice job summarizing kind of that surgical experience. It's typically a one-night stay in the hospital, and then you go home the very next day. Most patients, the vast majority, if not all, go home the next day. And then we're brought back for the generator placement, which is anywhere from 2 to 10 days after, really depending on a lot of other factors. And folks go home right after that procedure. You don't need to stay in that same town for a long period of time. You can go home after your surgery. The programming visits should be in person initially while we're doing a lot of that calibration. But again, a lot of the technology is headed into a direction to allow for remote programming in a lot of different ways. Some of it is using a handheld patient remote. Some of it is where we can log in, so to speak, to a Bluetooth where we can do the programming to the patient's home. Some of it we can do the programming to a local primary care, local general neurology office, and each of the different platforms sort of offers a bunch of different options there. Suffice it to say, just know that that's sort of where the things are headed. So I think I'll leave that there. Dr. Safarpour, we have a question about an upper age limit when perhaps there's a top number that we won't operate on. Is that a true statement? And if so, what might that be?
Really not. There's no upper age limit. It really depends on what we're trying to treat. If someone has good cognitive reserve and is a good candidate for surgery, we can do the surgery even if they're older. As I said, the goals for surgery may change over time, whereas when someone is younger and has some balance difficulties, we may say this may not be the best procedure for you because your balance can get worse and you may use a walker or wheelchair sooner. If someone is older and already wheelchair bound and needs tremor control to be able to feed himself or herself, then that person may be a good candidate for surgery because we're still improving their quality of life. They don't need to worry about balance anymore. But for improving quality of life, for management of tremor, we can still help them. So the answer to that question is no upper age. And then there was another question that someone's asking, why not doing the surgery immediately? I take that also as a range of when we operate. So usually we need at least 4 years for the symptoms of Parkinson's disease to progress in order for the neurologist to make sure that the diagnosis is correct. Because when we do studies and we follow up patients 4 years after diagnosis, other symptoms may come into picture that may change the overall diagnosis, and they may not have idiopathic Parkinson's disease anymore. So if we operate on someone who was just starting to have symptoms 6 months ago, we may operate on a whole number of patients who don't really have Parkinson's disease. Then the final outcome may not be very good. So generally we wait at least 4 years.
That's excellent. We have a few other questions in the chat, but I think that we've gotten to the end of our hour and we wanted to give you all time to head to the breakout rooms, and certainly we'd love to continue this conversation. Jen, should I bring you back to describe the breakout rooms, or how are we going to do that process?
Absolutely. I am back. Thank you, everybody, for such a robust conversation about DBS and great questions. This is a topic that we could talk about for hours, I am sure.